Thank you, Hannah. Good morning, everyone. First of all, I'd like to do introductions. So if we could start with the people who, if we could start with the count, please, so if everyone knows who everyone is. Thank you. Hannah, do you want to go around? Sorry, I can't hear you.
We'll just give it 2 seconds until the live streaming started.
Oh, has it not started yet?
Not yet, no, it takes a few seconds. We're good to go now, Councillor Bell.
That's great, thank you. So if we could do attendees of the meeting, so Hannah, if you wouldn't mind going to round who is in attendance, sorry, then who hasn't, who's in the apologies. Sorry, I can't get my words out this morning.
Okay, when I call your name, if you just confirm that you are present, that'd be great. Councillor Bell.
Yeah.
Councillor Donoghue, we've got apologies for. Councillor Chow. Councillor Heslop.
Yes, present.
Councillor Layton, we've got apologies for. Councillor Lee, we've got apologies for. Councillor McEwen.
Yeah, I'm present, but I'm on audio because I'm away at the moment and my signal's not very good. Okay, thank you.
Thank you, Councillor. Councillor Newell.
Hi, yes, I'm here.
Thank you. Councillor Tostevin.
Yes, present, Hannah.
And Councillor Wright.
Good morning, present.
Thank you. And we've also got Joanne Todd from CDDFT, and we've got Lisa Ward, who is observing. We've also got Diane Lax from Health Watch and Michael Horton from the CCG.
That's great. Thank you very much, Hannah. Item number 2, can I ask, is there any declarations of interest for the meeting?
Chair, it's Councillor McEwen here.
Sorry, Councillor Tostevin, did you have your hand up?
Yes, I did. I'm on the Board of Governors for County Durham and Darlington Foundation Trust.
That's great, thank you. Councillor McEwen, did you have your hand up, or did you say something?
I apologise for not raising my hand.
No, that's fine.
May I declare an interest? I'm a lay member of Darlington Primary Care Network.
Okay. And also, I'd like to say that I am one of the bank healthcare assistants at Darlington Memorial Hospital as well. So thank you very much. Any further declarations of interest? No. Okay. We're going to ask everyone to put themselves on mute during the meeting, just so we don't get feedback. That would be great as well. And if we could go to item number 3, and if we could go through the quality of accounts, that would be great. Is this? Who's doing this on behalf of Miriam? Because I know Miriam can't make it today.
So I've just I've attached a report here just for members to consider the County Durham and Darlington NHS Foundation Trust Quality Accounts for 1920, just to enable the committee's input into the draft commentary. So I'll just hand over to Joanne Todd.
That's great. Thank you.
Thank you, everyone, and thank you for inviting us. Just a couple of things to say at the beginning, if you don't mind, before I go through where we got to this year. Lisa's with me because this will be my last quality accounts because I'm retiring next year. So Lisa will be leading on the quality accounts going into next year. So that's the reason I've asked Lisa to come this morning with me. Very, very different this year with the quality accounts due to the COVID-19 pandemic. As you know, we usually have an external audit of the quality accounts, and that's where they just look that we've included everything that we should include in the quality accounts. That was stood down nationally because of COVID, and also we usually have a local indicator that's decided by our governors, and we had decided what the local indicator would be for audit, but again that was stood down nationally because of COVID. The timeframes also changed this year due to COVID. Usually, as you know, we have this produced and out by the end of June, and we've been told nationally that it doesn't need to be produced or submitted until the 15th of December. But because we'd done so much early work at the beginning of the year before we went into the the rise in hospital inpatient cases, we decided to move forward on it because we were in a position to get it approved and get it uploaded at this point once we've had comments from yourselves and our other key people who do feedback to us. So a little bit of different this year, but I hope that you've found it useful and that everything that's in there is nicely explained. I did also do a crib sheet, but that came in a little bit later. So if anybody does want to see the crib sheet that just goes through very, very briefly, then I'm sure that can be shared around yourselves if you haven't received it in the meantime. So going to the quality accounts, if everybody's happy, I'll do what I usually do at this point, and that's just to pull things through. And then please, if anybody wants to ask anything, please feel free to do so, because that's what this is all about. So falls is always on our quality accounts, and as you know, a couple of years ago we got a falls team in the organisation, and we started a 3-year strategy, and actually that 3-year strategy will conclude in April next year. But because falls and the problems with falls because of our elderly population and such like, we're certainly planning to do a further 3-year strategy. So the first of the 3 years, the first thing we wanted to do was just do a full review of where we're at with falls, put some quality improvement work in, and really make sure that all of our policies, our assessments and everything else were in place. And I'm pleased to say that we've got there with that. I guess the next 3 years will be around consolidating everything that we've done, seeing where we go from that, and also doing some further links out to the community services as we've started doing. In terms of our performance with falls, you'll see that the acute falls, we actually had a slight rise in those per 1,000 bed days to 5.8. Now, last year it was at 5.5 per 1,000 bed days, and the national average, we think, is about 5.6. That's very difficult to say whether that remains the national average, because it's been quite a few years since they've done proper national averages on it, but we always link ourselves over to what the latest is. So in terms of acute falls, we have had that slight increase. We've had a full review of that, and especially in terms of COVID, because as you can imagine, we got a lot of elderly people in and a lot of very sick people in. In real terms, in terms of the number of falls, we haven't seen a great increase in falls, but we did stand down some of our elective work, the actual beds per 1,000 bed days, and the number of patients through the doors does seem to have affected our figures a little bit, but it does show that we've had that slight increase. In terms of community falls in our community hospitals, we absolutely remain on track of where we want it to be. We've had quality improvement work, and I think I've shared it with you in the past, but things like our Red Zimmer Frame project, which has been very, very successful, and we're using that as standard across the trust now. So that's anybody who has a cognitive impairment. What we thought was the grey Zimmer frame against the bland background can cause people not to see where their walking aids are and such like. So we've introduced the Red Zimmer frames for those patients who are vulnerable, who might have cognitive impairment, who might need to be able to see things more clearly. And line and standing blood pressure, which was one of our other goals, to make sure that people coming into hospital, if they're vulnerable, have a line and standing blood pressure, because, you know, if you stand up suddenly, your blood pressure can drop. We've actually built that into our nerve centre system, which I know a lot of you came to have a look at over the last year, to see how we do a lot of our clinical assessments and such like in the electronic system. So that's been built into the system, and we continue to monitor that people are using that. So activity wise, in terms of falls, still a lot to do, but still remaining really key as part of our quality accounts, and we're taking it into the next phase. I think it would be very wrong of us to take that out. In terms of community falls in our community hospitals, we actually had a slight rise in those per 1,000 bed days to 5.8. Now, last year it was at 5.5 per 1,000 bed days, and the national average, we think, is about 5.6. That's very difficult to say whether that remains the national average, because Patients with dementia, again, as you know, this has been in the quality accounts for quite a while, but and I know that I've always had your support to keep that in the quality accounts, because we see a lot of people with cognitive impairment, and we want to make sure that that remains a real key priority for us as an organisation. We have our dementia lead now, and we also have the team being built. A lot of these things have gone on pause a little bit because of COVID. We're building them back into the system, but the team that will come in and help patients if they have cognitive impairment and they need that little bit extra attention. So that team is in place, but there has been, you know, with these really strange times that we've been in, there has been a little bit of a pause, but we're stepping that up again. In terms of our healthcare associated infections, with MRSA, we didn't reach our threshold, which is at 0, and we actually had 6 cases reported during 1920. A lot of that was to do with skin contamination. So we've asked the infection control team to do some deep dive work into making sure that any catheter related devices that go into veins, that we're auditing against that, and we're making sure that the practices are absolutely correct. With other patients, what we found was they maybe had a chronic wound, which means that they might have been colonised with the bacteria, and that means that it's on the skin surface, and because you've got an open wound, it can get into the bloodstream via that open wound. So absolute focus on MRSA bacteremia, and unfortunately we didn't reach our threshold. As we know, it is a national threshold of 0. We don't see 0 MRSA bacteremias. I don't think anybody does, but it's just to show that we've got that real focus on try and aim for 0 every step of the way in terms of MRSA bacteremia. Clostridium difficile, I haven't been able to rate that this year, because if you remember last year nationally they changed the definitions of Clostridium difficile. So what we used to have a threshold against was hospital acquired Clostridium difficile, but that's now joined with the community services. And so we have 2 separate things. It's hospital acquired and it's community onset, but we put those numbers together. So you'll have seen a big rise this year in our numbers of Clostridium difficile, but that's purely because we've brought into the community element. The threshold that we were given was 45 for year end, which is a big leap from the year before, which was 19, but that's taken into account this community element, and we came out at year end at 49. So we were very close to the threshold that we were given, but we did go over it a little bit. In terms of Clostridium difficile, we remain really proud, actually. When you look nationally, we're in a good position in terms of Clostridium difficile. We're keeping a very close eye on it this year, because with COVID, sometimes people get secondary infections, and that can increase antibiotic usage to deal with infections. So we've got the fortnightly meeting where we absolutely scrutinise any healthcare associated infections that have come through to make sure that we stay on track, and we do a full review of anybody who gets MRSA bacteremia or a Clostridium difficile to make sure that any lessons that need to be learned are learned. Pressure ulcers, again, we had an improvement on last year. If you remember, across the board we had 10 where on analysis we found that they were healthcare associated. This year we've had 6. That's 4 in the community setting and 2 in the acute setting. Again, we do a full review to see if there was anything we could have done differently, and we remain a 0 tolerance on that. That's a goal we've set locally, because we just want to have 0 healthcare associated. As you know, sometimes this is to do with documentation, but we come down really firm on that. If it's not written down, then we can't say that it's not healthcare associated. So if we don't see things written down in evidence when we do the review, then we would call it healthcare associated, and that work continues. With our discharge summaries, we continue at around about 90% compliance of getting those letters out within 24 hours, but you know our threshold's 95%. So although we're getting close to that 95%, we haven't managed to do it this year, and there's work streams continued with that. In terms of incidents and sepsis, that's moving forward really well. We've got sepsis. Every patient that comes through the door is assessed for their risk of having sepsis, and we do that using the early warning score. So it does trigger on our electronic systems. And again, I think you came to view that quite recently, but it triggers on our electronic systems to say, has your patient got sepsis? If they score high on their observations, sometimes that's because of that clinical condition, but it puts that question in for the staff to say, check if your patient's got sepsis because we've got a high score. It might be due to something like a heart attack or something else that's going on, but it triggers the staff to absolutely look for that to see if we do need to treat that patient for sepsis. And in terms of incidents, we within the national average. We remain within the national average for reporting of incidents. We've had a work piece go on this year, or 1920 I should say, and it's running into this year, and that's just to improve on our near miss reporting of incidents. We want to move on to the next step and get those incidents reported through where somebody might have seen something, it was avoided, so there wasn't an incident. But if we can see a rise in the near miss incidents where somebody's intercepted to stop an incident happening, but they've still reported it, it means that we can dig in further into those incidents and say, is there anything we need to put in place to actually avoid this happening across the board? So it's very good for learning. And as you know, we've got our link nurses for patient safety who are out on the wards and helping us with that journey. And we do have a fortnightly patient safety forum so that we review our incidents and look at any themes that are coming through, and we share any themes and any learning across the board. So that covers the patient safety element. As you know, with quality accounts, it goes into 3 areas. So that's the patient safety element. Moving on to patient experience element, nutrition and hydration in hospital. We've now got our quality metrics, so it means that we've got the audits, they're ongoing within the wards, and we're looking at, have people had an assessment for their nutrition? And again, I know that you've been very helpful with us about where we should go with our nutrition and hydration and the metrics that we should look at. So they've been built now, and they're built into the ward and department ongoing audit programme that the staff carry out, and we monitor that really closely. With end-of-life care, we're very, very proud to say that at our CQC assessment, we were rated outstanding for end-of-life care, and that's just fantastic news, really. And we are very proud. Within quality accounts, as you know, there's a huge amount of work goes on around end-of-life care, but within quality accounts, what we wanted to look at was whether people had died in their preferred place of death. And what we've found is that we are within the national framework for that. That's an ongoing work because we absolutely want people to be able to die where they choose to die. So that runs into next year as well. Everything that I'm talking about this morning is running into next year's quality accounts. Responsiveness to patients' personal needs, and that's where we send out the patient survey and we ask them the key questions such as, did somebody explain your medications to you? And again, when we've got those results back from the patient survey, it shows that we're on track within the national average for all of those indicators. Then we've got the staff survey, and in terms of the first key question that's asked there, the percentage of staff who would recommend the trust to family and friends, we have had a significant improvement on that. And as you know, we have struggled with that in the past. However, we're still below the national average. So that's identified in the quality accounts that we remain below the national average, but there has been significant improvement on that indicator. With the other two indicators, we've got significant improvement, and we're shown as better in some cases in terms of staff survey. So that's the percentage of staff experiencing harassment, bullying or abuse. And this is our staff's view on that. And what we've found is the trust score is better than the national average for that. And then the other one is the percentage of staff believing that the trust provides equal opportunities for career progression or promotion. And we've improved on that score, and we're now above the national average for that as well. So still more work to do on the first indicator, but on the other two, we're really pleased with the results with that. Friends and family test, we did struggle with during COVID, but we're having a relaunch of that this month, and a relaunch of how we capture that data to ask people if they would recommend the trust and their experience and such like. So we are looking at an electronic methodology for capturing that data, and that will be launched before the end of the year. So that's the experience section. And then we move on to clinical effectiveness. And the first one, which is a mandated indicator, are our mortality standards. So we do measure in two different ways. Standardized hospital mortality index is the first one, and that's the one that did show a slight increase. Now, when you measure your mortality indicators, what you're looking at is whether you are as expected. And then we've also got the hospital standardized mortality ratio, which is the HSMR part of that mortality index. And if you did see a rise in one, you immediately looking to see that what it looks like in the other one. So in terms of the first one, we've seen a slight rise. In terms of the second one, it's absolutely as indicated. If you see a rise in that, it does not mean that you've got a problem necessarily. It means have a look and see if there's something going on. What we've noticed, what we've found when we've looked into this, is that our depth of coding, now when you're looking at depth of coding, what that means is, are you pulling through not just the reason the patient came into hospital, but actually any comorbidities that they might have, so any underlying condition that they might have. We need to improve on the depth of coding, because if you only give the first indicator, when you're looking at a standardized mortality index, what that does is it'll only measure the risk of dying from that one condition. If somebody's sitting with lots of conditions that sit under that, that might increase the risk of dying. So we've got a task and finish group started, and that's looking at depth of coding. The second element was that looked as if it was on the rise was acute kidney injury. And I'm really pleased to say, although we had to put a 3-month delay in getting the nurses in post due to COVID, we've now got our acute kidney injury nurses who are dedicated to identifying any patients where their renal function isn't as it should be, and making sure that the management plans for that are robust. So lots of work going on in that, but really good things that we've identified that don't give us massive cause for concern, but absolutely shows where our learning should go to next, and making sure that we stay on top of that. Readmissions to hospital within 28 days. If you remember when we started this, and it is a mandated indicator and it went back a few years, but there was no intelligence out there of what the average of readmission was. So we pretty much put a finger in the air and said, let's aim for 7%. And if you remember when we did the stakeholder events earlier in the year, we realised, because we've now got intelligence, that actually people go between 11 and 12% for readmission to hospital within 28 days on average nationally. So we had agreement from everybody, and we also took it to our trust board to aim for 12% readmission rate this year, and then challenge ourselves further as we get improvement. I don't know that we would ever get to 7% in reality when we look at it in hindsight. And this year we got to 12.9%. Now that is an improvement on last year, but there's still work to do. And sometimes people are readmitted because they're sick, and you could never ever have predicted that. But the big thing is to say, is there a reason from discharge where we could have done something differently to prevent that readmission? So we are coming into where the national average is, but we continue in that work piece. The emergency department indicators, as in previous years, we still struggle with those. COVID has put a completely different, I would say, element into there, because we saw lots of changes in activity. But when we look purely from 2019 to 20, we didn't achieve our goals for the 4-hour standard for people being assessed and treated within the 4 hours. And there's a lot of detail in the quality accounts to explain that. So I did ask the team that deals with that to make sure that it was very, very detailed for yourselves in the quality accounts, so that you can see exactly where we're at and what work streams are ongoing to try and address that. Patient reported outcome measures. Now that's where we send questionnaires to people who've had hip surgery, knee surgery, hernia surgery and varicose vein surgery in the past. This year they're not reporting on varicose vein surgery or hernia surgery. And what we are looking for is, do people have an improvement in their health from after they've had the surgery? On the knee replacement questionnaire, that's coming within national average. On the hip replacement questionnaire, that's come outside of national average. So we haven't had responses that show that they felt their improvement was where we wanted it to be following the surgery. As you know, with this one, it is in as a mandated indicator, but that data is very, very dated. It's sometimes from the year previous, and there are questions on whether they'll be asking for that to be included in the future, because we're not actually getting our performance for this year. We're getting it usually for the previous year when once it comes through the national statistics. So that's something that nationally is being looked at. Maternity standards, and as you know, we've got 3 maternity standards. The first one is breastfeeding intention, and you can see with that we reached 57.3% of our ladies who agreed to breastfeed, and we've set ourselves a goal of 60%. That's the national goal, so you can see from the report that we haven't actually reached that. In terms of stopping smoking in pregnancy, nationally they ask us to aim for around about 22% maximum of people smoking in pregnancy. Despite doing all the work to try and stop that from happening, we came out at 16.9% of ladies who continued to smoke. And then the 12-week booking, and that's to make sure that our ladies come in and get themselves booked in for that pregnancy to maintain their health throughout the pregnancy. And we aim for 90% on that from a national standard, and we actually hit 90.8%. So successful in 2 elements, but certainly in terms of the breastfeeding, we continue to strive to do that, and there's lots of work streams sitting around that. And then finally, because from yourselves in the past you said put some really good things in. So we decided to do the excellence reporting this year, and it's been a phenomenal success actually. And what we do is we use the incident management system, but we use a different element of that so that people can put a report in about their colleagues if they really feel that somebody's gone the extra mile and they've tried really hard and they've done something fantastic. We have the system set up now so that feeds back to the individual to say that somebody said they've done a really good job, and it also feeds to the managers, and it produces a report for the care group governance meetings on a monthly basis, and the staff actually love it. So it's nice to get some positive feedback as well. So that's working very, very well. That takes us through the indicators. There's a couple of things that I do want to highlight to you, and you will have seen it in the report. We did report 3 never events this year. April 19 to 20. I know we're late in the year. I'm living in a bizarre world at the moment. But there was 3 never events reported during the period. One of those was a patient who went to theatre and was to have a rod put into the femur bone from a break in that bone. And what they actually did was they chose the wrong rod. They did realise that during the procedure, so they could change that, but actually there was a breakdown in process that it wasn't recognised until they started to insert that rod. The patient never came to any harm, but it's resulted in us having lots of lessons to learn to make sure that we continue to shout out in theatre. And what we've got is what's called a prosthetic pause we've introduced, and that means that when you're looking at the prosthesis that's going into the patient, you actually stop all activity within that theatre, and you have everybody look at what is being put in, and everybody agreeing that it's the correct one. So although the patient didn't come to any harm, that was a real lesson learned for the staff. The second one was what's called high strength Midazolam. Now Midazolam's a sedative, and you use it in anaesthetics, but you also use it for outpatient type settings or day case type settings, and that's where patients are coming in and they need a little bit of sedation for what procedure is being carried out. And we use it for things like people having the camera down their throat, just to settle them down and knock them a little bit sleepy. We use high strength midazolam in our high level areas such as intensive care if you're actually wanting to put somebody to sleep. It's a low strength midazolam that you put into your sort of outside areas where you're just wanting people to be sleepy. We've always had that in place, but there was a national shortage of low strength midazolam, which meant that nationally people had to move high strength midazolam into those outer areas and make sure that the dilution was correct. And unfortunately, they didn't dilute the solution correctly. Again, down to processes. The patient was absolutely fine, but we always report when we've done anything like that, so that we can make sure that we learn the lessons from it. The reason there was a national directive to move high strength midazolam into your high usage areas where you're actually wanting to put somebody to sleep is because of that risk, but because of this national shortage, the risk had to be reintroduced nationally, but our practices weren't robust enough to make sure that the dilution happened. So that's all being addressed, and like I said, the patient was absolutely fine. Then the third one, again, a very unfortunate one. It was a patient who came into the emergency department. And as you know, never events are just things where you should have very tight processes to make sure that this can never happen. It doesn't mean that the patient's come to any harm. And again, with this patient, no harm caused, but the patient came into the emergency department. With our medical gases, we have air coming through the wall, and we also have oxygen coming through the wall. What we leave as standard is oxygen coming through the wall, and if we need to use air, we plug the air cylinder in to the wall. The ambulance men came in, the previous patient had been moved out, and there was a huge emergency, so all of the staff had to dedicate over to another patient who was in the resuscitation area. The ambulance service, to help the staff out, actually attached the patient to the cylinder without realising that it was still an air cylinder rather than an oxygen cylinder during that period, but the staff had been pulled away from the bed area. So human error, no harm to the patient, but it's about making sure that you've cleared that bed space and you've checked it, which they do as standard, and there's lots of signage and such like, but the patient for a short period of time was administered air rather than oxygen, and obviously needed oxygen because of that chest condition. So they didn't come to harm, but again, our processes should be tight enough that can't happen. So lots of lessons learned in regards to those three during the year. And then the other thing that I'll point out to you is that we did have a Regulation 28 this year, and a Regulation 28 is where the coroner raises a concern that at inquest he's looked at the issue that's happened and thinks we could do more to turn that round. So in terms of this one, and it was purely the way the report was written, the way the coroner read it was that we had separate documentation for our allied health professionals as our nursing staff. We don't. We have a multidisciplinary record that everybody writes into, but what the coroner had read was around the nerve centre where we do our assessments, and thought that that was an electronic system for the nurses and a written record for the physiotherapists, and was worried that they weren't brought together. So we've given our assurances to the coroner that that's not the case, and a lesson learned for ourselves in the way we write these reports for the coroner. But we've absolutely given assurance that that's not the case, so the coroner is content with that. The other element that he raised was that the family described that the patients had to share walking aids during the patient's episode of care. What we've put into the wards or into the organisation as standard is a backup store of walking frames for people who come into hospital who might not have their own, so that we can get one out of storage and we're not relying on people using them within the ward area for more than one patient. So a couple of things to learn from that, and all to the good that the coroner actually highlighted that to us so that we could address it. The final thing I'm going to say, and then I will stop for breath, but the final thing I'll tell you about is another element around learning disability standards, and they've gone into the quality accounts this year, and that came from the Chief Nursing Officer recommending that all organisations included the learning disability standards. So you will see that in the report what that means, and that we start to report out on that year on year. So the standards are in there, and we'll make sure that we pull through the progress on the learning disability standards as we move forward. But again, that'll be something that'll get included as standard, and a very, very important thing for us to put in to ensure that we're moving forward and ensuring that quality improves in that area as well. So as in other years, we don't expect to see a sea of green, because if we see a sea of green, we're not challenging ourselves enough, and this is all about quality improvement. But I think we have moved forward in a lot of the areas where we aimed to last year, but still lots of work to do, and I'm sure this will go on for many years to come after I've gone. So thank you very much.
Thank you very much, Joanne, and thank you for presenting to us today. Has anyone got any questions for Joanne on the report? Is everyone happy with it? Councillor Tosterdon.
Thank you, Chair. Yes, it was just a couple of disappointments really in terms of you saying that the staff experience section, that the staff themselves are finding it a good place to work, the sort of equal opportunities, a reduction in bullying and harassment, and yet those same staff can't then sort of report that it's a good place to receive care to the family and friends. So to me that sort of seems a bit of a dilemma, and I just wondered what it was behind that statement that they can't actually recommend it as a good place to their friends and family as a place to receive care.
Yeah, and I think you're right, and it's a question that we've that we've struggled with for a little while, and actually this year is the time when we've seen a real step improvement in that indicator. You'll see in the report, and I'll refer you to the page numbers, but they're putting lots and lots of things in to just try and dig in to what that means, because what we would not want to do is say that it's due to the pressure in the NHS, because that would be the easy answer. So they're doing lots of things to try and get under that and understand it. But if I take you to page 52 of the report, sorry, I'm working off the hoof here, but it says there's been an improvement in respect of the staff recommending the organisation. There's been the improvement, but if you go over the page onto page 54, you can see the different things that our Human Resources and Learning and Development Department are putting on, and all of those are feeding into to try and understand it and to try and see what the issues are. So we've got the Staff Matters strategy that's been built. They have introduced a strategic leadership programme and a leadership conference, but we've also got leadership and management development frameworks, and also developing managers as well, because we want to make sure that we are, giving our managers the tools to work with our staff to get the good feedback. And actually what we can't do is criticise our staff for saying that, because that is what they're feeling. So we see an improvement year on year, but what they do from the staff surveys take it really seriously, and you can see by all of those things, which is the analysis from page 54 forward, where they're doing lots of different things to get under the skin of it really, and try and understand it and try and improve on it. They've also introduced talent management. Sue Jakes, our chief executive, she does breakfast with the chief executive, and building leadership and equality and diversity, inclusion and things like that. So there's a huge amount of work going on to just get our staff to talk to us and make sure that we're working towards getting that improvement and understanding where it comes from really.
Oh, thank you. That's good to see. I did have just one other question, if I may, and that's about the 4-hour standard wait in A&E. Obviously, from this committee's point of view, we were always keen to see the co-location of what was the walk-in centre up with the A&E, and we hope that sort of would reduce targets, and it still doesn't seem to have done that. And I just wondered whether things were progressing in terms of reduction, in terms of the two being co-located.
And as I said, there's a big section in there that shows the work that's ongoing with that, so you can see that in the report.
Yes,
I think our difficulty until now really has been due to COVID. We had to very, very quickly open 2 streams in each emergency department, so the suspected COVID and the non-COVID side. So we've had dramatic change. what we did see during the period was that our standards were on standard, but we've been in such strange times. You don't actually know the answer to that at the moment, because certainly the flow of patients through has been so very, very different. And during COVID, we absolutely reached our emergency department standards, but we've been in exceptional circumstances, haven't we? And actually, our elective work wasn't being carried out as much as it was during the COVID period, as with everywhere else. So, analysis-wise, at this point in time, probably not. Firstly, I'm not the right person to answer because it's not my area of work, and I'll certainly ask and get over to you a further analysis on that. But I suspect what they will say is it's very, very difficult to analyse it because of the dramatic and rapid change that we had to have due to the pandemic, and the real changes that happened there, and the beds that we opened that we wouldn't usually open, and using different facilities that we wouldn't usually use. So what I'll do, if everybody's agreeable, is ask our teams who deal with it to pull some intelligence together for you for the period post 1920, but certainly up to March, we didn't reach our standards, and the full work streams are included in the quality accounts to show you what we've been trying to do to address that. But I'll ask them if they can do an analysis post April the 1st up to the present day on what it's looking like and what we think about that, because that wouldn't be included in this quality account anyway. So if that's okay and agreeable to everybody, I can get that done.
Yes, thank you, Joanne.
Thanks.
Thank you. Joanne, I've just got one question. It's based on staff morale. I know there's a Facebook page that I've been part of since even before I started at the Trust. I was just wondering what impact that's had on staff morale, and just how you came about Facebook being the page to use, and is it secure? Because I know some of the questions that do get posted in there, I'm just concerned that other people might be able to see that who don't work for the Trust. Whether seen Stu posted something the other day, but before I even started back with the Trust, I was able to access that. So I was just wondering how that's managed.
It is managed by our communications team, absolutely, and I think, and this is a personal view, what I think is sometimes people just need to say things, and if they've had a difficult shift or anything else, people sometimes feel the need to share that, and what we don't want to do is keep that ramped down. What our communications team do is keep a very watchful eye, because we want people to have the freedom of speech, of course, that's the right thing to do, but what we don't want is for anything to come out that could be seen as inflammatory or anything else without any substance behind it. So our communications team lead on all of our communications, actually, so any sort of streams that we've got, and they monitor that. But if people want to post something, they'll post it anywhere, regardless of whether it's on the Trust Facebook or whatever else. I think what it does for our managers is allows them to see how their staff are feeling. If they're not, if for any reason they're not coming forward and say it, then it gives them the opportunity to go and explore that with that member of staff. On the other side, and really positively, we've had such fantastic posts on that Facebook page where we've had, we've really given our staff the feel-good factor with all the grateful thanks that have come in, and everything else, which during what has been very unprecedented times, and with lots of staff movement because of the situation that we're in, because what we had to do when we were building the ward areas for COVID and non-COVID was sometimes split teams, because what you can't do is put an element of very inexperienced staff all together. So we've had to, in some instances, split very experienced teams so that we're making sure that the staff who were maybe joining the organisation temporarily are getting the experience, and they're getting the leadership and the support from very experienced teams. But we've seen some fabulous things through Facebook. I mean, the doctors who came out of retirement to go and staff Bishop Auckland, lots of our nurses, lots of our allied health professionals who've really come up to the mark and helped us during this time. So there's a balance to be had, but I think in answer to your question, it is monitored, and it's monitored by our communications team. So that's absolutely in place.
Yeah, that's great. Thank you. Councillor Newell. You're on mute, Councillor Newell.
Hi, Joanne.
Yeah.
My question's actually been answered because it related to waiting times in A&E. And I've got to say, the feedback I've had has been that people have had excellent experiences, even post, April. I just wanted to say, I'm sorry to hear you're retiring. You and I go way back, don't we, looking at quality accounts. So I just wanted to say on a personal level, thank you very much for all the help I've had.
Thank you.
And I wish you well in your retirement.
Oh, thank you very much.
Yeah.
I know I do go back to the dot, I've got to say.
I know.
My ponytail has to get tighter every week now.
Good luck.
Thank you. Thank you. It's with a heavy heart, but I'm ready to do it. But I'll always love nursing. I've always been a nurse, and I will be a nurse in the future, I'm sure. But yeah, thank you. You'll make us cry, so you have to be very careful.
Much deserved rest, obviously. Any further questions for Joanne? No? This could be, this will be our last quality accounts. I bet you're excited.
It is my last quality accounts. No, I love the quality accounts, because I think from when I was given it probably 6 years ago, I thought, what on earth do I do with this? But by talking to yourselves and all of our stakeholders, I think we've built up a really robust report, and I think it pulls through all of our issues that we want to look at year on year. So sorry, excuse me. So although I sometimes come to these meetings with a sinking heart because we haven't got to where we wanted to be, and things like never events inevitably do happen, and Regulation 28s on occasion, which are very upsetting, it gets it out there, and it lets us all see how seriously we're taking it. And thank you to everybody for the contributions, and hopefully you'll keep that going with Lisa in the future, because she's got the quality accounts bag.
Brilliant. Well, if no one has got anything, is there anything else anybody wants to add to the session while we're all here? No? Well, thank you very much for coming, because I know you've been really busy, and I know we had to reschedule this, so thank you very much. It is much appreciated. And thank you everyone for joining.
Thank you. Could I just ask one question? Will you be putting a response in for us to go into the quality accounts?
Yes, we will do.
Yeah, great, lovely. It's just because we'll slot everybody's responses into the back of the report before we publish it. And thank you to Diane, raised a very obvious thing that just some wording I'd got wrong. So it's just the title that I should have used. So it's not going to fundamentally change the account. So I'll make that change as well. Okay. Thank you very much, everyone.
Thank you, Joanne. Thank you.
Bye.
Thank you. All the best, Joanna.
Bye.
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 Bingo.